Again, hopefully I convince you that everybody deserves an ablation with atrial fibrillation. I'm going to try to convince you that most patients with atrial fibrillation who have AFib, they'll need their left atrial appendage gone. So get ready for the ride. It's going to be fast, but we'll see. We'll try to convince you. Is there a role for left atrial appendageal closure in all atrial fibrillation patients? So I divide, when I look at a patient, I look at patients with this way. What's the risk of stroke? Low, medium, moderate, high. And what's the risk of bleeding? Low, moderate, high. If I'm dealing with an individual with low risk of stroke, irrespective of their risk of bleeding, I don't do any anticoagulation. There's nothing is needed. I don't need to consider about closure of the device. I'm not concerned about this individual. But let's look at the other individuals. So how do we define risk of stroke individual? We have this CHADS-VAS score, which is, or CHADS-VA, trying to get gender out. Congestive heart failure, hypertension, age, diabetes, stroke, and vascular disease. And the way we estimate the risk of bleeding is similar using the Hasbled score. And look at the common factors. Pretty much most of the factors that predispose people to stroke predisposes people to bleeding. So the reason for that, so there's no patients who have low risk of bleeding and high risk of stroke. If they have high risk of stroke, then definitely they have also higher risk of bleeding because they share most of the risk factors. The only difference are patients who have amyloidosis, hypertrophic cardiomyopathy, or significant atrial myopathy. But besides that, this group of patients here does not exist. So let's look at these guys down in the bottom. High risk of bleeding and some risk of stroke. I'm going to try to convince you that these individuals need their Watchman or need their left atrial appendigeal occlusion. We do have clinical trials that are going on right now, but all of us believe that oral anticoagulation is not the best option in these individuals. The risk of bleeding is very, very high. We have two clinical trials, the Apache and SOSTART, where look at patients who had intracerebral bleed, and they decided whether to restart oral anticoagulation or not. Guess what we see? We saw that, yes, if you restart oral anticoagulation, your risk of stroke may be lower, but the risk of rebleeding in the brain is very high, that we did not see any mortality benefit. So again, and these both trials showed the same thing. And when we look at the evolution data, which is a database that looking at patients who got Watchman and some of them had intracerebral bleed, what you see is that patients who've had intracerebral bleed and got a Watchman, the risk of stroke was lowered by around 80%, and the risk of bleeding was lowered by another 60-70%. This is our Cleveland Clinic data where we looked at patients who had intracerebral bleed. We found out that we were able to put a closure device, mostly here Watchman, in patients who had an intracerebral bleed, and they did very well with decreased risk of stroke. So in summary, these individuals here with high risk of bleeding and irrespective of the risk of stroke, they need to have a closure device. But there's a little bit of a concern about that because most of the time now we're doing the Watchman or we put another closure device. We like to give them oral anticoagulation for some period of time. So right now we have a newer device called the Watchman Flex Pro that's coated with material that repels blood clot. We're thinking that we're testing it right now in the simplified clinical trial. Dr. Walid Saliba, one of my colleagues, is a co-PI in this trial. And hopefully we can demonstrate that we can implant this device with just a single antiplatelet therapy. Now let's look at this group in the middle, moderate risk of bleeding and moderate to high risk of stroke. What can we do with this individual? We have plenty of data to support that, from PROTECT to PREVAIL to PROACT to evolution. And when you look at the meta-analysis of all this data, to get all these together, what you find in this group of patients, if you close their left atrial appendage and compare them to oral anticoagulation, whether warfarin or DOAC, the risk of stroke is similar. But look at risk of non-procedural bleeding was much higher with the oral anticoagulation. Risk of hemorrhagic stroke was much higher with the oral anticoagulation group. But let's look at mortality. What you see in patients who got left atrial appendigeal occlusion, their mortality rate is lower than warfarin or DOAC. And why is that? Why is that? It's actually very simple. The reason for that is with left atrial occlusion, the risk of bleeding is lower. And when we look at data, anybody who bled, irrespective where the bleed is higher risk of mortality. When you look at the other thing is the risk of intracerebral bleeding was much lower with the closure devices than with the DOAC. And why is that? Because when you give DOAC or warfarin, you can end up with a primary hemorrhagic bleed, but you also can end up with conversion bleed, meaning patients can get a ischemic stroke and the rate of hemorrhagic conversion is high. And that's why these individuals live longer if they have a closure device versus DOAC. And what's the third reason? The third reason I think is the most important reason. When we look at patients who had a stroke on DOAC or warfarin, or they have a stroke after a left atrial appendigeal occlusion, in the US mostly here, data from Watchman, although the number of stroke may be similar, the kind of stroke is completely different. The kind of stroke people get with a left atrial appendigeal occlusion are much milder, less likely to end up in disability, and less likely end up in going to a nursing home or assisted care facility. And that's why I think these individuals live longer if they have a closure devices than oral anticoagulation. Let's look at this group of patients here. There are low risk of bleeding, and they have some kind of risk of stroke. We have 3 clinical trials right now that are trying to look at that, the Champion and the Catalyst. The Champion is looking at Watchman Flex comparing to DOAC. The Catalyst is looking at the Amulet compared to DOAC. But the third one, which I think is the most important one, which was run by our institution, by Dr. Wozni, who was the PI, it was trying to look at patients who are going for an AFib ablation, and they got randomized to either continuation of DOAC or put a closure device at the same time of the ablation. And look what we found. We found is just by monitoring them for 3 years, we were able to significantly lower the risk of bleeding by almost 56%. Just by closing that device with similar risk of stroke. And that's important. This is what is going to end up saving these people's life, because guess what? They bleed, they go to the hospital, one complication after another one. So for these individuals, I hope I convince you that they need to have a closure device. And now let's look at this group of patients, the very high risk of stroke. Can I do better? You know, with all the data with DOAC and what we know, or with warfarin, is that when you start patients on oral anticoagulation and they have atrial fibrillation, you lower the risk of stroke by around 60%. But is 60% good enough? If somebody's risk of stroke in the next 5 years is 12% and you lower it 66%, you made it 5%. I don't want to have a stroke 5% in the next 5 years. I want my doctor to do better. So what about using both strategies at the same time? We've heard from Dr. Galanov earlier, when the surgeons actually looked at patients who are going for surgery and closed left atrial appendage and kept them on oral anticoagulation, the risk of stroke was lower. And the reason for that is because there's a lot of failure for DOAC, that people could have left atrial clot despite warfarin and despite DOAC. And our colleagues in imaging, they'll tell you it's not uncommon that they do a TE and they found sludge or atrial myopathy in the left atrial appendage. So can we do better, and do we have data? This is a small clinical trial, small observational data that looked at patients who've had a stroke on oral anticoagulation, and they looked at people who we decided to continue oral anticoagulation versus people who decided to use both strategy or closure device. Look at the risk of stroke. It's significantly much lower, almost by 40%, that if you do this. So that's why we have currently now the latest 4 clinical trial that's hopefully going to randomize patients with high risk of stroke and they have atrial fibrillation to either continuation of oral anticoagulation or using Watchman as well as oral anticoagulation at the same time. And we expect, what I expect is in the future, is that this group of patients is going to end up with both oral anticoagulation and a Watchman, and this group of patients may end up with oral anticoagulation plus half a dose, a Watchman plus half a dose oral anticoagulation. And with that, I can hopefully convince you that most people deserve their left atrial appendage to close. What about, where are we moving with this strategy? Again, we have this concomitant procedure that creates opportunities for us to handle that left atrial appendage. Dr. Galinov mentions that is if somebody's going to go do a surgery on the heart, it's okay to clip their left atrial appendage, especially if they have atrial fibrillation. So these concomitant procedures have created opportunities for us to handle the left atrial appendage while we're inside the heart. AFib ablation and closure device. This is a study that I summarized, published in JACC Advanced. It's our experience with the first few hundred patients that we decided to do concomitant procedures with AFib ablation as well as a Watchman, and which turned out to be a very safe and effective strategy. We did not find that doing an ablation interfered with the success rate of the Watchman, or doing a Watchman interfered with the success rate of doing an ablation. This is Dr. Kapadia's Watch TAVR. Pretty much that these procedures, doing TAVR and a Watchman, is also a very safe alternative to patients. This is from Osama's data, again, when doing ablation and Watchman. And with that, I hope I convinced you that close the left atrial appendage if you have an opportunity. Thank you.